All right, welcome. Today, we're flipping the script a bit. This isn't your typical explainer. No, this is a full-on simulation. Think of it as your consultant surgical viva. I'm going to be your examiner, and you're the candidate. Your job is to think on your feet, just like a real surgeon.
All right, you're in the hot seat. The exam starts now. So take a deep breath. No pressure, really. Just think clearly, be systematic. Here comes your first case.
Case 1, acute sepsis. So, imagine this. You get that urgent call from the emergency department. It's a critical situation, and believe me, the clock is already ticking.
Okay, here are the details. A 39-year-old guy, right upper abdominal pain, fever, jaundice, and it's been going on for 5 days. And then the kicker, he's hypotensive. Your alarm bell should be ringing off the hook right now. This isn't just a simple bellyache. This patient is sick.
So, how do you approach this? This is your first real test. Tell me, what is the very first thing you do when you step into that room? Go ahead, think about it for a second.
Okay, the number one rule, the thing you absolutely cannot forget is this. Resuscitate before you investigate. I can't stress that enough. Before you ask a single question, you have to tackle his life-threatening instability. That means your classic ABCs: airway, breathing, circulation. Make sure his airway is clear, check his breathing, and get those IV fluids running immediately to get that blood pressure up. Only when he's being actively resuscitated can you even think about drawing blood and starting your history.
So you get a bit more info. Stabbing pain in the right upper quadrant, 5 days, he's got jaundice, dark urine, pale stools, classic signs of a biliary blockage, right? His vitals are screaming sepsis, temp of 39, heart rate of 110. But here's the interesting part, a negative Murphy sign. Now, why is that significant? Well, it suggests the problem might not just be in the gallbladder itself, like with simple cholecystitis. This is pointing towards an issue deeper in the bile duct.
Okay, good work. The IV fluids are in, his blood pressure is starting to come up. You've done the first crucial steps. So what's next? What investigations are you ordering right now to lock down your diagnosis and figure out what to do? And the first set of labs are back. Take a look at these numbers. The pattern is pretty textbook, isn't it? You've got that cholestatic picture, the direct bilirubin is way up, ALT is a little bumped. But there's one number on this screen that should make you sit up and take notice. It's the one that's basically screaming emergency.
Yeah, that one. A white blood cell count of 22,000. Look, this isn't just some run-of-the-mill infection, this is severe sepsis. That number, plus how he looks clinically, tells you everything you need to know. You have to move, and you have to move fast.
And here's your confirmation. The ultrasound comes back and it lays it all out for you. The biliary tree is dilated, both inside and out of the liver. The common bile duct is swollen up to 9 millimeters. And there it is, the smoking gun. Stones inside the duct. You've now confirmed it. You have a blockage, and you have the source of his sepsis.
So you can walk back to the team and state your diagnosis with confidence: acute cholangitis. And let's be clear, this is a major surgical emergency. It's a life-threatening infection of a blocked biliary tree. He's got the classic Charcot's triad: the fever, pain, and jaundice. But actually, when you add in his hypotension, he's probably got some confusion too, right? That pushes him into Reynolds pentad, which is even more serious.
Okay, you've got the diagnosis, you've started the resuscitation. Now, give me the plan. What is the definitive management, step by step? Be specific. Where are you sending this patient, and what's the most critical procedure you need to get done?
That's it. That's exactly right. First, he's going straight to the ICU. No question. He needs close monitoring. You're going to keep him NPO, nothing by mouth, and keep hammering him with IV fluids and broad-spectrum antibiotics. And then, the most important piece of the puzzle, an urgent call to your GI colleagues for an ERCP. The goal is simple. You have to unblock that pipe. You have to decompress the biliary tree to get that sepsis under control.
But, of course, it's never that easy, is it? Here's the twist. The gastroenterologist calls you. They did the ERCP, they got a bunch of stones out, but there's one big one that's impacted. It's stuck. It won't move. Meanwhile, your patient is still sick, his bilirubin is still going up, so the non-operative plan has failed. Now what? What's your move, surgeon?
And that right there, that is the consultant-level decision. When endoscopy can't solve the problem, surgery is the answer. You have to take this patient to the operating room. You'll do a cholecystectomy, and then, crucially, you're going to explore the common bile duct yourself, laparoscopy, and get that stone out. That's the definitive move. Excellent. Now let's switch gears for case number 2.
All right, case 2, a hidden cancer. So just take a breath. The vibe here is totally different. We're out of the ER. This patient is stable, sitting in your clinic. This isn't about rushing to resuscitate. This is about being a detective. It's about careful, strategic thinking.
So here's the story. A 51-year-old man, diabetic, comes in with 6 months of this kind of vague upper abdominal pain. Okay? But then he drops this on you. He's lost 20 kilograms. That's nearly 45 pounds, and he wasn't trying to. That is a massive red flag for cancer. Your suspicion for malignancy should be through the roof from the second you hear that.
So what are you thinking? What's on your differential diagnosis list? Sure, it could be something benign, like chronic gallstones. But with that kind of weight loss? No way! Gallbladder cancer has to be number 1 on your list. Of course, you'll also keep other things in mind, maybe a big polyp or even a liver tumor that's growing into the gallbladder.
Okay, so let's say his initial ultrasound shows some asymmetrical wall thickening. That's suspicious, right? It's not definitive, but it's not normal. So what's your next move? What specific tests are you ordering to really nail down this diagnosis?
This is where choosing the right tool is absolutely critical. You need a really good quality CT scan, a triphasic liver protocol scan, to get a good look at that mass and see if it has spread anywhere. You'll also check some tumor markers. But here's a really important exam point. You generally do not biopsy a gallbladder mass if you think you can take it out. Why? Because you risk spilling cancer cells and seeding the tumor along the path of the needle. So if the imaging is strongly suggestive, that's what you act on.
And there you have it. Another piece of the puzzle slots into place. His CA19-9 tumor marker comes back high at 300. Now on its own, that doesn't diagnose cancer. But you combine that with what you saw on the CT scan, well, now gallbladder cancer isn't just a suspicion, it's your number 1 most likely diagnosis. Okay, so how do you manage this? It has to be step-by-step, no cutting corners. First, you finish the staging. Get a full-body CT to make sure the cancer hasn't spread. Second, and this is an absolute must, you discuss this case in a multidisciplinary tumor board meeting. This isn't a decision you make alone. If the team agrees surgery is the way to go, then the operation is an extended cholecystectomy. You take out the gallbladder, a piece of the liver next to it, and all the nearby lymph nodes. And one last critical point. In the OR, you have to send the cystic duct margin for a frozen section to make sure you got it all.
All right, let's hit pause on the simulation for a sec and talk about what we just did. Those 2 cases could not be more different, right? And understanding that difference, that's the real key to acing an exam like this.
Let's put them side by side. Case 1, the acute cholangitis, that was all about urgency. It was a sprint. Your priority was resuscitation and getting that biliary tree drained fast. You had to know your backup plan when ERCP failed. But case 2, the cancer case, that was all about strategy. It was a chess match. Your priority was careful staging and a perfectly planned, precise cancer operation. You needed to know what to do in the OR if a margin came back positive. See the difference? Sprint versus chess match.
Really great work today, but I've got one last test for you. Imagine we're at the end of the case discussion. I don't ask another question. I just sit back and I'm silent. I just look at you and nod. This is a classic examiner's trick. The silence is designed to make you think, what did I miss? So in either of those cases, what else is there? Did you mention post-op care, preventing blood clots? What about long-term follow-up for the cancer patient? You've always got to be thinking one step ahead of the examiner. That's what makes you a consultant. And with that, the exam is over.